Hey, why is this up? See, I be doing too much. See, try to be prepared and be messing it all up. How you doing?
All right, and yourself.
Oh, well, well.
Birthday week, girl.
Yes. I saw it was a post from somewhere and it was like, it's April. It's my birthday month. I was like, okay, I'll take it. I'll take it.
There you go.
How are you?
I'm okay.
Good. How was the rest of your week?
It was a week.
Weeks be weekend around here. Like, wow, I'm on the countdown into the semester. Woo, baby. Woo.
So you take your wins where you can get them.
You know, you know. Like, woo, countdown, countdown, countdown. Excited though. I think there are 10 students. I think there are 10 that were before me that's coming through this graduating. So I'm excited. I think it's 10. It might be no. I think it's 10 HIM students, and then the coding certificate students get to graduate as well. So I think there are 4 of those. So it may be a total of 14. So yeah, I'm excited.
Oh, good. Okay.
I'm excited for them. So because we're a virtual program, I don't know if everybody is coming. We'll see when we get there, right?
There you go.
But I'll be there to see the folks cross that stage, all their hard work, all of the stuff, all of the things. Ooh, yes. Okay, let's see what else is going on. I don't know. Well, we can go ahead and get started. Oh wait, somebody's in here.
Because actually, it's a lot going on, but that's definitely for the meeting after the meeting.
Okay, you digging in the bag? Wait a minute.
No, you hear me, don't you?
See you. We saw the bag. Come on. So it's like you digging in the bag.
Can I tell you? Let me tell. Look, I don't know what I'm turning into, like an old man or something. But literally, I pack a bag from when I go from upstairs to downstairs because I get tired. I'm like, oh my God, I left so and so upstairs. And then when I leave my bedroom, I actually have the nerve to act like I'm leaving the house. I do a look back before I leave. I'm like, wow.
Bless your heart. Now don't turn it into an old man. Like, let me make sure everything is everything before I move. I love it. Hey, lady. Thank you. I know she cracking up. Wait a minute. Let me see. Thank you. That's our crafty coder, our on the street correspondent. Hey, yes. Thank you. She's cracking up at you. Is turning into an old man, sir, and sir. All right. Well, welcome everyone to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss healthcare news, health information news, and healthcare news, I guess, both one and the same usually. Education, certification tips, graduation, birthday week as they weaken, and old man mechanisms. Mannerisms. Old man mannerisms. That's what I want. But also entrepreneurship and the revenue cycle at large. And so as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Well, before I introduce my co-host, let me share with you information on a free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start?
and scared of wasting time and resources? Let me help you with the right steps to become a certified, marketable medical coder. Learn more at bit.ly/5stepscoder.
Hey, see, you be digging too. I see. Hey. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, check the video description for the link. Okay, I hope I don't go deaf because I got this new thing to listen to the mic, and I swear to God, it is so loud. I'm like, Lord, I'm gonna lose hearing in my. We're not gonna claim that in my left ear because I'm like, why am I so loud? Calm down, girl. Calm down. Okay.
But you don't sound loud to us. Well, not to me.
Well, good. I
It's
don't
just
know.
clear. That's all.
I don't know what in the world. I tried to turn the gain down. I tried to do. Wait, is this the volume? See, I'm beat them. Oh, wait. No, because then that'll be y'all. I don't know. I probably need to read a manual or two because I downloaded this software that's supposed to go with this mic, and I don't know. It's just real loud in my ear. But we'll push through. It's all good. All righty. Joining me today is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a very long time. In 2014, I left the bedside and transitioned into medical coding. During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Mm-hmm. And how's that been going for you?
It's coming along. I started a new class Thursday.
I always love the beginning of your new classes. It sets us up for how they're gonna go through the rest of the class, but I love it.
And then I did tutoring. I had a tutoring session yesterday for Dr. Hill students,
Uh-huh.
and it is so everybody when they get into medical coding specifically, they always hit the wall because people really think this stuff is sweet. And it's just so funny how everybody, when it's all said and done, they put some respect on it.
Hey.
Because
Now that's the truth, Ruth.
yes, because one of the students, she's advancing, through the course, and she was like, when I first started, I thought it was going to be easy. It's an online program. I could do it from home. She said, I really thought, she said, I almost thought I bit off more than I could chew. I said, no, you just got to take little bites.
Little bites. Well, they say, how do you eat an elephant? One little bite at a time.
Mm-hmm.
That's all it is. I had a student call me who, well, she's not our student, but she called me interested in the program. And then it was like, so I can just take this coding and then I'll be certified and then I can go, right? I said, ma'am, let's pull up the curriculum first. Let me show you all the classes that are required. Well, are these required or are these optional? Can I just take these coding ones right here and be, no, ma'am. And when she meant optional, she meant like medical terminology. A&P. I'm like, ma'am, I had to turn around and look like, am I being pranked? Is this a prank for me? I don't know what's happening. All right, that's funny. All right, well, so before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Your opinion matters and is welcome here. So friends, use the chat. The chat is where we have our conversation. And sometimes we notice that y'all even be talking amongst yourselves, which is all good and fine, well, and dandy. Only thing we ask is that you if you have a question, that you put a Q first so that we know that question is for us and we don't miss it. So for those who are just joining us or watching the replay today, we are talking APCs and indirect billing, Medicare's $270 million question. As soon as I saw that article, I said, I had a lot of questions. I still have some questions, but we'll dive in a minute. But first, oh wait, let me see who else is in the. Good morning, Tanika. Good morning. Thank you. Yes, it slid right out. I was thinking Spike Lee. They only optional if you wanted to, if you only want to truly fail. Absolutely. Like where'd she get that from? All right. But first, let's get into our church announcements. Shall we? Hey. Y'all got y'all Easter outfits ready?
Yeah.
Hey.
I was watching a video, and it was a church video. Somebody had a tambourine that had lights on it. I'm like, now where do you get that?
Talk about distraction. I would be just watching the person with the lights, like.
And you know, I said she probably bought that at a church conference somewhere.
Somewhere, you know, because they doing all the things now, all of the things. Ooh, Lord Jesus. All right. So let's see, what did I find? Did you know? So I didn't realize, and I figured, Mr. Jesse, you can help bring some insight. Let me turn this down. Bring some insight. Nurses have a documentation burden too.
Oh, that's been. Mm-hmm.
They complaining about the documentation burden as well.
Mm-hmm.
Okay. Well, they're dabbling over here in AI world as well. So I saw, I think it was in Modern Healthcare, there was a story about Epic working or piloting AI tools for nursing to enhance their workflows and to reduce their documentation burdens. I said, well, here we go. Nobody is going to be documenting in a minute, right? Be like, everybody's stuff going to say the same thing. And they're going to say, delve into, so you know, I always know if somebody is using AI because they throw that delve. People don't say delve. That's a whole AI word. And every time I see it, I be like, that's an AI word.
Speaking of AI, you know, there's you know how they advertise everything, but there is a guy on Instagram who has because he calls it like Black Magic AI or something, and he has a whole list of words that he puts in his query for AI not to use. Mm-hmm. And I bet you Delve is on there.
I bet you it is. I was listening to a radio commercial, and I said they done wrote that. Because it straight said there. Oh, I have to look at that to see, because then I'll be listening for folks like, did they say it? Okay. So these AI tools for nurses are being tested at Baptist Health and Stanford Healthcare. And then they're also using ambient AI on smartphones to record and document relevant conversation data in EHR. And then they also said Meditech is also working on ambient documentation for nurses as well as therapists and home care providers. Did I tell y'all about my instance of a provider that I was taking him to my mom? My mom had a doctor's appointment. I was taking her to her appointment, and her regular doctor was unavailable. And so they scheduled an appointment with him. And he was like, explaining to her, and I was like, sir, I'm the one you need to pay attention to. But he was explaining to her, do you mind if I have my phone out to record the conversation? He was, and she's looking at me with the big eye, and I was like, well, I just want to see what it looked like on the back end. So go ahead, go let's see what it looked like. So needless to say, when he finished and he uploaded something, but he put it in the wrong chart, I said, strike one. So then he was like, oh my God, I put it in the right chart. Or the wrong chart. So I can't, what do you say? So I can't tell you something because I think it automatically you can't have cookie cutter, you shouldn't have cookie cutter documentation. So it automatically tried to personalize it by adding names and that kind of stuff in it when it uploaded into their system. And I was like, oh, you got a fancy little ambient AI, huh? And so he was like, but I can tell you some of the things. And so he read like the script verbatim, what it was that it uploaded that was based on the conversation and the questions that he asked. So I was like, well, y'all funny. I was like, but he still had to go in and tweak some stuff and still had to go in and do some things. But I was like,
but getting back to this nursing burden, see, the only difference is when nurses don't document properly, they get locked up, unlike doctors.
Where is my tea?
That was the truth, because like it just happened.
Oh, we remembered that one lady.
Well, actually, and it happens. It's happened a couple times since then. There was another recently, a lady was arrested because she put that the person, this was back when I was working a nurse, and they never say that a person is, resting in the bed with their eyes closed. Come to find out the person was dead. But you can't, but that doesn't,
that's not even funny.
It doesn't specify anything. Like you're not saying that, because there's a whole little thing you have to, well, not a whole little, there's phrases you have to use to indicate that you saw the person's chest raised, you heard them snoring, something to indicate that there's signs of life. Because if you just put resting in the bed with their eyes closed, they could have been dead for 8 hours,
Oh my God. She is crazy. Who would be the extra person with the tambourine lights? I just had a whole, and then you looking and seeing and begging and all over the place. Bless your whole heart. Good morning. Good morning. Oh my goodness. That's crazy. Yeah, you got a point about that. Okay, let me see. The other thing I wanted to say, as we're going through this administration, there was Health and Human Services budget document that was leaked that said that they are proposing to stop publishing two of the CDC's, I think they're weekly documentation, or two documentations that they actually have. One is the Emerging Infectious Disease and Preventing Chronic Disease publications. And so, yeah, they want to eliminate they also wanted to eliminate the National Center for Chronic Disease Prevention and Health Promotion and all associated programs. And then as well as eliminating funding for the CDC's Global Health Center, as well as HIV eradication efforts, and some public health funding. So, yeah, like Lord, please don't send down another pandemic, because we ain't gonna make it. I don't think we're gonna make it.
It's getting ready to be 19th century Europe around here. People will be walking. It's just going to be all kind of infestations. It's just going to be a mess.
Oh my God. Yeah. So those were my church announcements for today. Mr. Jesse, did you have any church announcements?
I actually have a church announcement / just a gripe.
Okay.
Because I almost want to pour out a little Red Bull for the people who are in the struggle of looking for employment, because this is for the meeting. After the meeting, I'll go into detail. But can I tell you, I had an interview this week. There were, not including myself, there were 10 people in the meeting. I'm not exaggerating. In what world?
I just was for what?
Thank you.
How long was it? An hour? How long was the interview? So were people just watching? Were they just observers to the process?
All in all, it may have been 20, 25 minutes. Nobody asked me anything. What it consisted of was they had pre-set questions.
Uh-huh.
And what they did was the facilitator was calling on different people. Do you want to take the next 2 questions? They would ask me the questions or a follow-up question, then they would go. I'm like, and then the coup de grace was they get to the end. It was, honey, look, you'd have thought I was trying to get on American Idol or something. But even at that, it's only 4 people, ain't it?
Right.
They had the nerve to have a case study. So she puts, because they get to the slide, it says case study. So she's given the parameters. She's like, oh, well, we're all gonna go off screen. So as to not make you nervous, so you don't think so you won't see us all looking at you, but we're going to be here. You just review it. So I said, wait a minute. I said, before we do that, how many case studies is it? Because I was like, if they'd have been like 2 of them, we want to stop this right here. So she said 1. So I said, okay. I just like this process. These people have to stop with the foolishness. They really, really do.
Oh my God. Oh my God. I don't understand. Oh yeah.
I don't either.
I know we're gonna dive in more. So stay tuned for the meeting after the meeting. I'm sure there are gonna be tears flowing by the end of that conversation. Oh my goodness. Was there anything else, or was that the only announcement you had?
My other announcement is you people who listen, like they really, really need to listen. I always got a target on my back. Look, I don't know nothing, okay? Nothing. But
None of us do. None of us do.
So I really think people need to join the meeting after the meeting, because my takeaway from this week, have your own. Have your own.
Oh, I felt that. I think I need a double shot.
I'm telling you.
Ooh. Oh, Teddy, I'm sorry you experienced that situation.
It's called life.
Ooh,
you got it.
Life.
Mm-hmm.
Jesus. All right. Well, let the tea spilling begin, because this right here, ooh, child. So, all right. So today, again, we're talking APCs and indirect billing, Medicare's $270 million question. So again, welcome everyone to another piping hot episode of the Saturday Morning Tea, where we spill the tea on everything revenue cycle. I'm your host, Clarice Warner, the girl with the pearls, and my co-host, the coding nurse. And we are ready to dive into today's, it's this fascinating topic, but I just want to say crazy topic because, oh, she said, say it again for the people in the back and the front. Absolutely.
That's right.
Because, Jesus. Okay. So today we're discussing this study that was published in the Journal of the American Medical Association. So that right there tickled me the most.
Because you already know. You already know.
That tickled me the most. Like, really? Do the other doctors know about this? Did they publish this? Do they know? I don't know. Maybe there's some infighting, and maybe they want to pop out and show up. I don't know. But that tickled me first and foremost. But anyway. Oh, so this study is about the indirect billing within the Medicare physician fee schedule. And so this is crucial information for everyone in medical coding and billing. So the 2025 study by Mulcahy and colleagues reveals some eye-opening statistics about advanced practice clinicians, or APCs, and how their services are billed to Medicare. Most of us know this, but in the event that you don't, I'll give you some history. But before we jump to that, let me make sure that you all understand why this is important and why this matters, especially if you're coding for practices with advanced practice clinicians. And those would be your nurse practitioners, your physician assistants, or clinical nurse specialists. This directly impacts your facility's revenue, compliance efforts, and could expose you to audit risks. So let's start with the basics. What exactly is indirect billing, you may ask? So there are two ways advanced practice clinicians can bill Medicare for their services. They can bill directly or they can bill indirectly. Direct billing means that the APC submits the claim using their own National Provider Identifier, or NPI. Indirect billing, which is also called incident to billing, I know probably people are rolling their eyes right now as soon as I say it, incident to, means that the service is billed under the physician's NPI, even though an APC provided the care. Now, there's a financial incentive for indirect billing. You know there had to be a reason why.
That's right.
So when APCs bill directly, Medicare pays only 85% of the physician fee schedule rate. But when they bill incident to a physician, Medicare pays 100% of the physician rate. So there's a 15% difference that creates a strong financial incentive for practices to bill indirectly whenever possible. So she said, oh yeah, a whole ortho conversation. So this indirect billing practice began with the Rural Clinic Act of 1977. So it's been around for a long time. But it expanded significantly under the Balanced Budget Act of 1997. The original intent was to support physician practices in underserved areas, but it's grown considerably since then. And yes, there are specific requirements for when you bill incident to. Most of us know it. Those in the compliance world, again, I'm sure y'all rolling your eyes right now, like, really, for real? And this is where many facilities get into trouble. So for incident to billing to be appropriate, there are several conditions that must be met. It can only be for established patients, not new patients, and not new problems. The physician must have initiated the course of treatment. The physician must be physically present in the office suite while the APC provides the service. It's not allowed for any Medicare Part A services. It's not permitted in certain settings like hospital outpatient departments. So you see, with all of those types of requirements, this is where folks get into trouble. And the biggest one is the physician requirement. So many practices incorrectly bill incident to when the physician isn't physically present in the office suite. And then another common error is billing new patient visits incident to when that is explicitly prohibited. So these errors, of course, can lead to significant audit liabilities. And we've seen several studies that show from the OIG why it continues to be a problem and on their watch list. Okay, so let's look at what this study found. And the results are off the charts. All right, so in 2022, 38.9% of all care provided by advanced practice clinicians to Medicare beneficiaries were billed indirectly under a physician's NPI. Mr. Jesse, you know how to move. That's 37.6 million encounters. 4 out of 10 APC visits aren't being tracked as APC care. That's a problem. But anyway, the financial impact is huge. Medicare fee-for-service, or FFS, spent $1.8 billion on indirectly billed APC care in 2022. If all that care had been billed directly, Medicare would have saved the $270 million in that year alone. Y'all count them numbers? That's $250 million. And interestingly, the percentage of APC-provided care billed indirectly has actually decreased from 45.1% in 2016 to 38.9% in 2022. But the absolute number of indirectly billed encounters has increased significantly because more APCs are entering the workforce. And when they're entering the workforce and they're working in these provider clinics that have physicians, more often than not, what did we say? What was the 4 out of 10 of those APC visits are being billed to those physicians. Sit on that for a minute. All right. So again, what about, we have Medicare Advantage and then we have traditional Medicare. Well, the study found higher rates of indirect billing in Medicare Advantage. 43,
no joke.
43.7% of APC care was billed indirectly in Medicare Advantage compared to 35.7% in fee-for-service Medicare. And that was surprising because Medicare Advantage plans have financial incentive to reduce the cost. That was another thing. Like, wait a minute, hold on. So y'all playing this game with an organization that is supposed to help reduce the cost of care for these beneficiaries, but make it make sense. So those were the things that were like, first is in the JAMA, then you got, it's so much. Okay. She said tattoo all the requirements on the dominant hand so they could see it. It wouldn't even matter because they'll still be calling in from wherever they are talking about, yeah, I was there. I called in. All right. So all of the things. Now, you should know that evaluation and management services make up the vast majority. So 76.7% of all indirectly billed services are evaluation and management services. The remaining services were, there were 4.5% in tests, 6.7% in treatment, and 6.6% in procedures, as well as 5.4% with imaging services. So, of course, evaluation and management visits are the prime target for incident to billing. And of course, that makes sense because E&M services are the bread and butter of most practices. Now, this is where it gets really interesting. The study examined how indirect billing varies across different physician specialties. Most people would probably think that primary care has the highest rate since they employ so many APCs. But actually, that's not what the study found. Surgical specialists had the highest rates of indirect billing. It was 29.7% of encounters billed by surgical specialists were actually provided by APCs and billed incident to. So that's almost a third of their Medicare encounters. On the other end of the spectrum, primary care physicians had the lowest rates at just 3.9% of encounters. So that was crazy. And then the average physician, so the median physician in 2022 billed indirectly for 11.1% of encounters, which is up from 6.5% in 2016. That means half of all physicians bill more than 11.1% of their Medicare encounters for care that was actually provided by APCs. So for many physicians, a significant portion of the work credited to them in Medicare data was actually performed by somebody else. And this has major implications for quality measurement and alternative payment models. So think about it. If you're measuring a physician's quality metrics, but 11 to 30% of that physician's work was actually done by a different clinician, how accurate are those metrics? Yeah. Or as we're, looking at value-based payment models that attribute patients to providers based on who bills for most of their care. So the Medicare Shared Savings Program and other alternative payment models typically attribute patients to physicians based on claims data. So if APCs are delivering care, but physicians are on the claims, this attribution becomes highly inaccurate, right? Well, this is the other side that folks don't really think about. Like, really? This way? Okay. So let's talk about what all this means for our audience of health information professionals.
These comments are jumping.
I'm coming to know. Wait a minute. Okay. Wait. Don't be getting lunch at Starbucks. Absolutely. Talking about I'm right around the corner. Or I'm out of the suite in the Starbucks at the hospital. Just say, woo, chap. All right. They like to do that when PA not enrolled yet. Like, just don't bring them on until enrollment is finished. Right.
Exactly.
This whole topic got me needing a Cinepril IV. I'm glad you can't hear me talking to the screen. I knew it was like eye rolling, all kinds of stuff. Like, make it all make sense, right? And this is, again, some of the things that you don't really think about. Go ahead. Are you about to say?
I just have a question. And actually, I know somebody who's in a nurse practitioner program now. I want to know what type of reimbursement education do nurse practitioners get? Because do they, in terms of what they can bill for, like this whole incident 2 thing, like, are they even taught how to about it at all?
It depends on the practice. So there's and the primary reason why, and I want to thank my Ohio Nurse Practitioner organization for posting the information about the study. That's where I found the study from. Because remember, APCs basically can bill on their own. They can, in a lot of states, they can stand alone, they can bill their own. They don't have to have all of these things. But even in those states, there are several practices where they're used to assist the flow of the work and help the physician, see the patients and all of the things, because there are only so many physicians. You have all of these patients. They need help. They needed help. So they employ the APCs to backfill to see the patients that the physicians necessarily can't get through. Now, again, there has to be an initial visit for the patient and the provider. So they have to establish a relationship, but from then on, they can pass that patient off to the APC, who will then see it. But the physician gets the credit for it, and the physician and the practice can bill at the 100% physician fee schedule for it, because they bill under that physician.
Right.
But all of this skews the data, and nurse practitioners are fighting because it's like, you can't see the value, you can't see the quality, you can't see all of this. It's all of the stuff that the APCs are doing is masked under these physicians, because this stuff is based on claim data. And the claims going out have the physician on it. It doesn't have the APCs on it. So the APC, there's nothing to say, well, this is my quality. This is the quality that I provide to patients. This is, unless you're billing directly. And so this is kind of a plea, again, for that direct billing of the APCs, not only for them to get their compensation, but also for them to be able to show the work that they do, the quality of the work that they do. And they can attribute, because APCs can bill and set up shop, they can attribute some of those dollars to APCs, or some of those patients, which equals dollars, to some of those APCs as well in these Medicare Advantage programs.
Right, but my question was, is this
Did I not
being
answer?
taught?
Like, go ahead.
No, is this being taught in NP programs? And then also, it also, yes, it has to be. It cannot be for new patients, but also if there's a new problem, then a nurse practitioner or an APC cannot diagnose a new problem. They have to see the physician to be diagnosed with a new problem. Then they can go back to being seen.
So they can, for incident 2, they can't do a new problem. They can,
Right.
so if the patient comes in with a new problem, there's a decision that has to be made. We APC bill it directly on our own, or we have to have the physician establish the treatment plan and protocols for whatever that new problem is in order for it to be
100%.
Correct. So then, and the funny part is, you don't know, because sometimes, typically, you know that it's a new patient visit because you've never seen the patient, or the patient hasn't been seen within the 3-year cutoff. But sometimes patients come in like, oh, well, since I got you here, let me tell you about da 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 da, and that changes the whole dynamic of the visit, and that's what catches them. That's where you run into some problems, because really it's in the documentation that that's something new. She said, my mom is a retired nurse educator. I need to wake her up for this. Mama up. She can watch the replay. It's so much. I'm stuttering. Like, why, on the most basic level of understanding, it doesn't make sense. Yeah, she said, I doubt it's being taught. If it is, somebody needs to teach the teacher.
But all of
they
this
need awareness. They should definitely have awareness of what's going on. And from my experience in working with a facility that employed a lot of the APCs, it was crazy, because, and I think we talked about this either last week or the week before, where we were talking about the RVUs and how, in a lot of places, physicians are reimbursed based on those RVUs. Well, think about this. Those RVU credits are also going to those physicians. So then the APCs are getting caught out here like, wait a minute, we're doing the work, but how are we not getting the credit for the RVUs that are actually happening? It's a mess. It's a whole mess.
It is. And I understand in theory why they even have incident 2. I get it.
I get it.
Right. But I just think that it has just become so muddy. I really just think they need to just stop it.
Well, from my compliance perspective, when we have offices that come in and talk about, because they see the dollar sign, they think it's the financial incentive to be able to bill 100%. And it's like, but do you understand all of the things? And if you don't have a good process to manage it, and most people don't do it. We would tell them all the time, don't do it. And then of course, we're just giving our opinions. We're just telling you based on the information. The decision maker has to make the decision. We just provide the information. You have to make the decision. You have to be able to determine whatever your risk aversity, where you lie with that. So they'll jump out there like, okay, well, we're going to try it. Then they be walking it back. Oh, well, help us, because we done messed up. Yeah. So now you got some potential liability for the 6 months that you tried to play this game and couldn't do it. Yeah. I said, listen, I have a cousin that's an MP. 2 of our cousins that went to the MP passed on. We need to look at quality. Absolutely. Data quality of care, trends, and training and education.
Absolutely.
Yeah. Absolutely. Because again, this is messing up all the data. This is a mess. And did people think about that? Now I knew all about incident 2, all about think, but I never thought about how this impedes the data quality for those APCs. Never crossed my mind until I read this study. I said, oh my God, they're absolutely right. Absolutely.
And this also ties into why, or this kind of, when you think about it like that, this whole incident too is what also keeps or APCs in some states from having full practice authority, because there's nothing.
They don't want to let that money go.
Mhm.
They like,
So
no, they hold no.
it's such a complex conversation.
Mhm.
I mean, that's the thing. Like, I don't think that the average person, because I know even I've been in this a minute, and I'm still, surprised sometimes. Like, people have no idea how much money circulates in our healthcare system
Mhm.
every year. They have no idea.
A lot. So let's talk a little bit about the compliance risks. So oh, no, I skipped the part. I'm sorry, because we done got caught up. So specifically for the coders and billers. So first and foremost, documentation is critical. We all know that. And the medical record must clearly document that the physician initiated the course of treatment. Again, they have to have that first initial visit with that patient for that problem. The physician was physically present in the office suite, and the service was for an established patient. Now, the compliance risk, the Office of Inspector General, or IG, has flagged incident to billing as a high risk area for decades. Audits regularly find that 25 to 50% of the incident to services don't meet all the requirements, and they have to meet them all. This is not an if and or this and maybe or what. All of them have to be met. Again, the most common issues are no physician presence during the service, new patient visits billed incident to, and no documentation of physician involvement in the plan of care. These violations can result in significant repayment demands and potentially false claims act liability. So, coders can do the following to help their facilities. And these are what would be considered, I guess, best practices if they're playing in this game. Again, I always say, if you don't have this stuff ticked and tied to the nth degree, don't play in this game. Don't play in this. So create a clear incident to policy that defines when indirect billing is appropriate. Develop a scheduling system that tracks physician presence in the office suite. Perform regular internal audits of incident to billing, because those audits will let you know real quick, we need to stop. Everybody stop playing. Track the percentage of APC services billed directly versus indirectly. Consider the financial impact if Medicare were to eliminate incident to billing, because that's a thought. What if this goes away tomorrow and y'all still trying to play this game? So it may not even be an option. Let's see, what about the future policy changes? Is Medicare likely to change these rules? Where the Medicare Payment Advisory Commission, or MedPAC, has recommended that Congress require APCs to bill Medicare directly for their services. So this is going to even get even more fun, right? So if implemented, this would eliminate incident to billing entirely. So physicians need to be, or facilities need to be thinking about the concept of this and how this may impact them, and preparing for this possibility, right? Right. All right. So go ahead. What you gonna say? I hear you breathing.
Me personally, I don't think that, and I just don't think that providers in healthcare in this day and age are capable of self-regulation. I don't. And I just think that this is only going to get worse, especially since, HHS has been gutted. Like, who's going to, we have
Right.
nobody for enforcement.
Right.
You have nobody that's going to come. I mean, who's going to track the data now? You have less
And
people.
this study was done before the change in the
Right.
administration. So,
Right.
so yeah, the whole, all of this could change in a pin stroke. So you're right about that. You're right. Even with the strength that we had in the OIG, that's even up for grabs. So let's summarize the key takeaways from our little talk today. So indirect billing is widespread. 38.9% of all APCs provided care to Medicare beneficiaries is billed indirectly through a physician. Again, this billing practice costs Medicare an estimated $270 million annually that could be saved if all services were billed directly. Surgical specialists have the highest rates of indirect billing. They're at 29.7%, while primary care has the lowest at 3.9%. The overall percentage of indirect billing is declining, but the absolute number is increasing as more APCs enter the workforce. Medicare Advantage has higher rates of indirect billing than fee-for-service Medicare, and documentation to support indirect billing must be meticulous to avoid compliance issues. Indirect billing distorts data about who is actually providing care to Medicare beneficiaries. Yeah, so these are some questions that you should be asking yourselves after this. Does the facility have clear policies on when APCs should bill directly versus indirectly, especially if you're out here playing in this game? Are you conducting regular audits to ensure compliance with Incident 2 requirements? And how would eliminating indirect billing impact your facility financially? And does your documentation adequately support your Incident 2 billing practices? Things to make you go, Yes, yes, yes. So yeah, like I said, I took away a couple of things, and then I chuckled on a couple of things as well. Because again, this came from the Journal of the American Medical Association, their little publication for studies. Like, did this one slide in? Did somebody be like, "Oh, really?"
Dr. Jasmine, I totally agree.
She said
You
this
don't hear nobody
needs to be
talking about
taught. New ACPs need to know how this impacts data collected about their patient outcomes. Absolutely. I'd rather see information about this than the hundreds of videos about how they went from RN to MSN in 6 months. Uh-oh.
it. Absolutely.
Wow. Right. Because then, all of these different payment models are going to look at the quality and the information based on that provider. What do your numbers look like? What does your data look like? What is it telling people about you? Because a lot of it is public information. Be out there in your bag if you want to, and your data and your quality don't look right. You have a problem, ma'am and sir. APC. Yeah. So like I said, I took some things away. I hope you took some things away from this as well. I think it was good, and particularly for those who are working in practices that are operating under an Incident 2 model, or 2 considering operating under an Incident 2 model, or failing in the Incident 2 model that you're working in. Yes, this is a money, quality, data, and every other interdependency.
It is.
Absolutely.
And you can easily see how it can get very muddy very quickly.
And I really think there needs to be some more deeper conversations, particularly in the APC realm, on these impacts. Really, I do. All right, y'all. Hey, I didn't think we was gonna make it. Because we got off track. I didn't think we was gonna make it. But look at us.
Everything comes down to money in this system, which is, it is what it is. It was created long before any of us came along.
Absolutely. And just the amount of money is like, whoa. Wow. That's why healthcare is a big business. Big business.
Mm-hmm.
Don't sleep. Don't sleep. Don't sleep. All right. Well, are you thirsty for fresh perspectives on the healthcare revenue cycle? Ma'am, wait a minute. I cannot. Wait a minute. Hold on. I peeled off all my gel nails and my anxiety went up. Let me call my mama. Bless your heart. I'm sorry about that. Now you have to redo your manicure.
Because these are truly rabbit holes that you can really go down this one and be down there for a long time.
Mm-hmm.
I mean, white
Like,
hat
well, wait
with
a
the
minute.
flashlight and
How does this
all.
impact this?
Yeah.
And how does this impact that? And what is this? And what is that? Like, yeah. Yep. All right. So let me get this done so we can head out. All right. So are you thirsty for fresh perspectives on the healthcare revenue cycle? By becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. So why sip alone when you can steep in knowledge together? So come, let's spill the tea on industry insights. Here's what you can expect as a valued member of the PRNT sippers: exclusive healthcare insights. You can gain access to in-depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, revenue cycle best practices, and we even throw in some entrepreneurial resources as well. Early access, especially since we're going to talk about that today. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever-evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And then my personal favorite, community connections. Join a private community of healthcare professionals where you can network, share experience, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you for considering becoming a member of the PRNT Sippers. For the cost of 2 cups of regular tea, not that other stuff, a month, you can join the community. So check out the link in the description of the video, or you can go to bit.ly/the PRNT Sippers. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. Let's see. Said this one should have came with an anxiety sensitivity warning. Yeah, if y'all messing up manicures and all kinds of stuff. Absolutely. So thank you all again for joining the Saturday morning tea or checking out the replay. Let me ask you, was the tea spilled today? If so, put your teacups in the chat. So as always, before signing off, I have a special request for all you amazing viewers out there. If you found this episode helpful, don't keep it to yourself. We all need to know this, especially if you have friends, family, and colleagues that are APCs. Share the information, share the episode, share this by hitting that share button. And hey, why not subscribe to our channel while you're at it? That way, you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. Do you have some additional thoughts or questions or experiences that you want to share about today's topic? Well, we would love to hear from you. So continue to drop a comment below and let's keep this conversation brewing. And if you enjoyed this episode, again, give us a thumbs up. It helps more healthcare professionals find our content. And also, check out the Coding Nurse channel on YouTube and Instagram. Yes. So remember, at the Saturday Morning Tea, we're all about building a community of savvy, informed healthcare professionals. So like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any closing thoughts for today?
This was another great topic. I mean, it's just, I feel everybody in the audience because, it's hard when people don't want to listen. It really is, but great topic. And I'm just grateful for the platform.
Mm-hmm. She said, tea sippers, set it and forget it, and you won't regret it.
Mm-hmm. And the thing that I like most about this is for all you people who are on the fence about whether to join, like it really goes down in the meeting after the meeting. Like we really do empower people to think outside the box, to become entrepreneurial, and we hold each other accountable for what we say we're going to do, because that's how you advance.
That's right. That's right. And we cheer and celebrate the wins. We again look for solutions with the questionable losses. Like, well, wait a minute, let's see, what can we do differently? How can we approach things a little different? Let's talk through some of the things. So we have a good time. Good time is had by all. All right. Well, this has been a great session today. See you tea sippers at 10:15 a.m. Eastern Standard Time. And remember, be safe, be kind, and don't wish for it, work for it. Take care and have a great weekend.
Happy Easter.
Oh yeah, I forgot. I'm sorry. Happy Easter, everyone. Well, I didn't your Easter outfit.
And don't forget, I don't think we're going to be here next week.
That's right. And we won't be here next week. I'll be traveling, but we'll have a very hot topic, a real hot topic, the following week. So enjoy your Saturday morning. All right.